Okay, good afternoon to all. Can you all hear me?
Yes, sir.
Okay, good. So I'll share the slides and then can you all see the slides?
Yes, sir.
Anupriya, Santu Ghosh has joined. Maybe you can just make him as a co-host so that you can.
Yes, sir. I'll make it.
Can you hear me?
Yes, we can hear you. We can see you.
Sorry, I thought it would be, Zoom. So I was so reluctant to installing, but then realized that it is just the,
WebEx.
it was giving the warning just install.
No,
I
you
was
can
little
use
reluctant to
the.
install without knowing what it is. Then I realized it is the same thing what you send. It is the another, virtual media. Then I install and it's working because Mac always stop now. I mean this.
Just allow me to make some few slides presentation. After that,
Sure.
we'll ask you to share. And maybe I'll just do one thing. You can also see that whether you can share from your slides.
Yeah, let me try this.
Yeah, after that we will.
So allow some recording, some WebEx. Okay, I have to allow. Mac has a lot of cancel something wrong. Uh, can you see my?
Yes, we can see your computer screen, but not the presentation.
Now?
Okay, now your presentation is coming up. Put it in presentation mode.
Now? It's coming in presentation mode?
No, not yet. Yes, now it's come. Yes.
It's come now. So that means it's working.
Yes, it's fine. Now we can just unshare for some time, then I'll.
Yes. I answered now. It's work, right?
Yeah, it's okay.
Okay.
Okay, we can start. I think many have joined now. Yeah, good afternoon to all, dear friends and colleagues. Welcome to Air Quality Management lecture series. Today we are having a 60-second lecture. This lecture series we started in October 2020. It is first of its kind in India, and it provides an important forum for young researchers, scientists, engineers, educators, and practitioners to understand the latest advancements and theories and applications through expert lectures. Lecture includes recent developments, innovations, and use of recent technologies in the area of air quality management. This lecture also provides platform for collaboration with stakeholders, experts from various countries. So these are our eminent air quality management speakers in the past. So last month we have Neeraj Destogi, who gave a talk in the October month. As a part of this air quality management initiatives, we also started with the Air Quality Management Association. Again, it's also about 3-year-old now. The main idea is of this association is to enhance understanding the science behind air quality by promoting knowledge of clean air and understanding the best working practices to address air quality issues. Air Quality Management Association also addresses the issues of ambient air quality, indoor air quality, health risk, technological interventions, and policy formulations. It provides a common platform to interact with many stakeholders and to have mutual benefits. So this is our director. We inaugurated Air Quality Management Association way back in July 2022. Next. So this lecture series started as a part of the Clean Environment for Planetary Health in Asia. This was an UKRE funded project where we try to look at the interdisciplinary engagement and co-create lasting partnership with the help of instigate clean environment transformations in Asia. So several universities, stakeholders, industries were part of this forum, and we initiated this air quality management lecture series way back in 2020. So we also have an Indian International Conference on Air Quality Management, and this year the Indian International Conference for Air Quality Management will be held in IIT Delhi. So we have a winter school, also a conference. The conference will happen from 17th, 18th, 19th, and the winter school starts from 15th of December 2022. So more details are available in ISAQM website. So I'm very pleased to invite Dr. Santu Ghosh for the Air Quality Management lecture series. This is today, as I mentioned, it is 62 lecture. And now I'll ask Dr. Lakshmi to introduce Dr. Santu Ghosh.
Dr. Santu Ghosh is an associate professor in the Department of Biostatistics at St. John's Medical College, Bangalore, with over 20 years of experience in public health research. His work spans air pollution and health effects, public health, nutrition, and advanced biostatistical modeling, contributing to more than 100 publications in leading national and international journals and 3 book chapters. He has led and collaborated on multiple major research grants from several renowned agencies. Dr. Ghosh serves in several prominent professional roles, including as a steering committee member of CAPR India and consultant to the World Bank, United Nations Foundation, and ICMR-NIN, and had previously worked with UNICEF, contributed to the Global Burden of Disease 2010 project, and participated in WHO Guideline Development Group for Indoor Air Pollution in 2014. His research interests focused on statistical modeling of air pollution and its health impacts, the interplay between environmental exposures and nutritional status, and the translation of environmental health evidence into effective policy. Today's talk is titled Short-Term Health Effects of Air Pollution, Tools and Approaches in Epidemiology. This lecture focuses on how epidemiological tools such as time series analysis and case crossover designs are used to estimate the short-term health effects of air pollution. The lecture explains how daily fluctuations in pollutant levels are linked with outcomes like hospital admissions and mortality, providing timely evidence that can guide immediate and effective policy responses. We welcome you, sir, for the talk.
Thank you. Let me share my screen. Can you see the full screen?
Yes.
Okay, great. Okay, good evening, all participants. Thank you for joining this webinar for my lecture. So today I'll talk about a short-term effect of air pollution on health and its tools and approaches in epidemiology. Mainly, initially I thought of capture everything in this lecture, but while I was preparing the slide, I realized that everything cannot be done in one lecture. We can think later, but today's talk, I mainly focus on, I'll touch upon all, but more details discussion on the time series analysis for short-term effect estimations. So before we move to the actual, statistical aspect of it, let's discuss about some epidemiological aspects. I'm expecting that it could be a mixed crowd. So I'm, touching upon almost all the aspects of epidemiology here. So if some part could be, known for few and some may not be, so just, sorry. Why is not moving? So we know that the air pollution remains one of the leading environmental risk factor for disease and mortality worldwide. And the WHO 2025 estimation telling around 4.2 million premature deaths annually, significant disability adjusted life years, and particularly affecting low and middle income countries in Asia. And if you look at the Indian perspectives, we all know that the air pollution exposure is ubiquitous in major Indian cities. And for the study purpose, that air pollution is very much seasonal. When the October starts, Delhi people, start, getting the severe air pollution episodes there. So it's the season that impact the exposure. And then it is, and even if we observe, across in the health forum, you'll see that the growing burden of respiratory and cardiovascular disease is predominant in this country. Why it's not moving sometimes?
No, you can just use the keyboard so that it will be better for you.
Why it's not moving? Still, or enter?
No, you just do one thing. You can
right click also not working.
No. You can just. I think your computer is there. No, from there you can just operate it from the computer. Computer you operate it. You are using it mouse.
Yeah, I'm using mouse.
But you can in the keyboard it is there. No, upward arrow, downward arrow. You can just go keep.
Can you see this?
Now you can. It's going.
Okay, so I'm using here. Okay, fine.
Yes.
So now before we go to the acute effect of air pollution, we need to understand what exactly acute effect means. So let me compare against long-term and short-term. That might give you a much clearer idea about what short-term impact or the acute impact of air pollution is. So normally this impact, the time window we consider around hours to days. And it could be maximum of, it depends on if the air pollution we normally consider around 7 days, if the, temperature or something, 2 weeks or even in a month we consider as a short-term effect. But In air pollution literature, we normally consider 1 hours to 7 days maximum. Means is months to years. Whether there would be an immediate for short term, it could be an immediate effect, or it could be 1 to 3 days lag effects. And normally in short-term air pollution effect literature, you can find up to 7 days lag we consider effect. On the other hand, the long-term is more of cumulative exposure. It's for several months or several years. An outcome that we consider here is mainly hospital admission, the emergency room visits, mortality events, etc. Whereas the long-term means in the long-term damage in the body in terms of, say, lung function decline, asthma development, etc. And the study design is the time series is one of the famous study for estimating acute effect. On the other hand, you have case crossover and panel studies that also use. But for long term, we normally look for cohort studies, but cross-sectionally, sometimes we consider as a, the evidence is not so strong, but still we do cross-sectional study to understand the potential association. However, the cohort study is something that can give us more stronger, evidence for these associations. And in that, this acute effect, we consider entire population because in the time series, it's more of an ecological study, whereas long term, we normally prefer individual level studies. And if you consider the mechanism of this impact, it is basically, already pre-existing condition is there. It's just a triggering or exacerbations. So it is not expected that one people will die or one person will die just one day air pollution exposure. It happens because, some people already, compromise, immunocompromise or, some other health issues already, there. So due to a high episodes, it might cause some health, immediate acute response due to the immediate acute response of the body, get worsened and then triggering the whole situations. Or even sometimes suppose somebody is asthmatic, due to a high episode of air pollution, the asthma exacerbation start maybe, develop immediate wheeze and start all, manifestation of, asthma immediately within a day or two. So these could be. On the other hand, prolonged exposure cause a long-term damage. Sometimes it is not repairable. So this damage occurs with a, several months or several years exposure. Sometimes a decade-long exposure may cause even cancer. Then why we study acute effect? Now, one of the things is, it's easy to do because its immediate public health impact, health emergency occur within a day and requiring timely interventions. And the vulnerable populations, if you know that, you need to identify who should be actually, should be targeted if some air pollution episode is occurring, suppose in Delhi, they should be, more cautious, or they should not come out of the house, or should be in a much safer place with respect to the air pollution exposure. So for that, you need this or mechanistic insight for, acute response. If you are interested to know, if suddenly, you expose one person to a very high level of exposure, what could be their, health response, through the inflammatory pathways or autonomic dysfunction. And it also policy relevance because, we, as you all aware, that the air quality index is one of the indicator often we use to understand what is the air quality of a particular geography. So to understand the air quality index or to understand the potential health warning under that particular conditions, the short-term effect studies are required. And another thing is that, if you are interested to understand the air pollution and health effects, any association with any particular health, response or health outcomes that's not yet explored or may have a potential for short-term effect. So this is a very quick study, low cost study that you can plan, and that's why, basically we consider this as a low-hanging fruits, all depending on the secondary data, you can conduct this and very quickly. And what are the biological, pathways for short-term effect? If you look at first, let's look at, before cardiovascular, look at the respiratory pathways. It's actually, especially actually irritate the, airway epithelium, or, the other pollutant may cause inflammatory, activate the inflammatory cascade, and that actually release the pro-inflammatory cytokines or neutrophil infiltration, etc. And that cause, and as you know that this inflammation make the lung, vulnerable for any kind of infection, or not only lung, the entire, even upper respiratory also would be vulnerable for any kind of infections, and people get the upper respiratory or even lower respiratory infections due to this exposure. And it also can cause, actually increased airway resistance may cause, and your shortness of breath and the mucus hypersecretion cause your, so it can develop the spasm, and, you can, over time, you can develop the wheeze. So these are the, respiratory pathways that we often see. And if you look at the cardiovascular pathways, this is actually systematic inflammation triggered by the pulmonary inflammatory response. Autonomic nervous system dysfunction alter the heart rate variability, blood pressure changes. So, just consider these, when you are looking for some short-term effect, what could be your outcome that you should consider. So these are the things. You can look at the heart rate variability, you can look at the blood pressure as an outcome that can actually impacted by short-term exposure, or even the oxidative stress, it actually generation of reactive oxygen species, that overwhelming antioxidant defense system, that even if you can measure the oxidative stress in the body, that could be another outcome, or the markers you can consider as the health outcomes and correlate with air pollutions. And it can be a thrombotic pathways, that we know that the heart attack and everything may happen or occur due to air pollution exposure, that in this pathway it can actually enhance the platelet aggregation and blood coagulation cascade activations. These are the pathways by which can cause MI and other things. And it also, and even not only even the endothelial dysfunction and the vasomotor change. Vasomotor change means the mechanism of the nerve that actually control the it's sometimes our air vessel get bigger and smaller, narrower and wider. This whole thing is depending on the body, so it's controlled by one nervous system, and that also get impacted. And if when is required, when it won't get widened, then it would be a huge problem. You might get a blockage, etc. So that cause health problems like MI, stroke, acute heart failure, etc. And that may cause the hospital mortality, in-hospital mortality, etc. These are the outcomes that you can actually consider. And who are the vulnerable population? Those who are have a pre-existing disease like asthma, COPD, coronary artery disease, diabetes. They are the more susceptible to get acute effect of air pollutions. If you look at the age, the younger children, especially under 5 children, and elder more than 65 years are more vulnerable for this acute effect. And even there is a sufficient evidence that the women is more susceptible for air pollution, acute air pollution health effects due to many other reasons. I'm not going in details. And the lower socioeconomic status, that is the same reason why the women is in some part of is a socioeconomic status. And then there are some genetical factor, as you are aware, that some people just it's kind of allergen, that often the air pollution, due to the air pollution, that the allergy occurred, and then get the asthma conditions aggravated, or even if not, then even get upper respiratory and then lower respiratory infection because of this genetical susceptibility. So that's why genetical factor is one of the important factor. And the key outcomes I already discussed. I don't discuss much here, but few things that we normally consider as our main outcome of interest in this particular part of the epidemiological analysis is, say, daily all-cause mortality, daily hospital admission due to respiratory or cardiovascular illness, or daily emergency room visits, etc. Often we consider as the outcome, or sometimes, even some, use, or some medicine, maybe some allergy medicine use, daily allergy medicine use. Whenever you see that in a pharmacy that that medicine use has increased, that means it could be due to the high air pollution. So that's why these are the indicator outcome variable we consider often for this kind of analysis. I'm not spending much time on air pollution of concern, because I presume that group is aware about the, predominantly from the exposure science. So, but just for all, it's a particulate matter, PM10, PM2.5 fine particles, you can consider nitrogen dioxide, ozone, sulfur dioxide, carbon monoxide, or volatile organic compounds that we consider may have the impact and short-term impact on human health. So now, in a we are entering into more complicated part of it, the exposure assessment and the effect estimations. So first, let's understand what could be the potential data source for this kind of analysis. Air quality monitoring station that they monitor regularly, by either CPCB or State Pollution Control Board, even Tamil Nadu Pollution Control Board is there. So they monitor, they have a few stations where they regularly monitor air quality, even if there are some continuous air quality monitors across India. That also you can consider controlled by CPCB, where every day they are monitoring, and the State Pollution Control Board may not monitor at each stations, but however they have a rotational mechanism by which at least 2-3 monitors are active every day for measuring the air quality of a city. And other source is, most emerging source is the satellite-based air quality estimates, the aerosol optical depth-based air quality estimate validated by the ground level monitors. Often we use as a, indicator of 24 hours air pollution exposure in a city, or, any geographical locations if you mention. And the temporal resolution could be hourly, could be daily, or could be 8 hours. Even if you look at the Pollution Control Board, they have a mechanism of measuring every 8 hours because of the filter they need to change every 8 hours. So 8 hours average we often consider, or 3 8 hours average as a 24 hours average we consider. If we look at the exposure metric, what are the exposure metric normally we can consider for this kind of analysis? One of the most common, exposure metric is the 24 hours average concentration, ambient concentration. 24 hours average ambient concentration, often considered as the exposure, air pollution exposure metric. But, sometimes one might say, that, air pollution means it's a mixture of different pollutants. So how just one air pollution is enough to understand this response? Yes, I agree. But for that, you need to have some mechanism to combine them and come up with an index. So air quality index or air quality health index are some, is that kind of index can combine all all air quality, air pollutants and come up with an index, and that index can be considered as one of the air pollution exposure metric, and you can understand the effect of that index on air pollution. That means there would be studies, you can see that people are examining the impact of air quality index on daily mortality or daily morbidity or daily hospital admission, etc. And other metric could be, as I mentioned earlier, that it may not be just same day effect or 1 day effect. It could be, 2-3 days cumulative effect can also consider as a short-term effect. So that's why the lag effect is something that we consider. So lag exposure, distributed lag exposure is one of the exposure metric we often consider to understand the actual short-term effect of air pollution instead of just a single day exposure. That will come in details in this lecture. Sometimes this also not working. Now it's working. So now if you look at the different epidemiological study designs, the mostly two study design are most common is the time series analysis, which is normally considered as a gold standard for short-term air pollution effect, and then case crossover study. The case crossover study is also one of the very strong study where same event can be considered, same individuals event can be considered as control, maybe 1 week, 2 weeks, or 1 month before the event occurred. So that way a case crossover design can be considered. However, there are some evidence that indicating that time series analysis, the effect estimate from time series analysis more precise and less biased compared to case crossover design. There are ample of studies you can search. There is one important study that I can tell, that Joel's one study. Joel's did simulation and showed that time series study is much more efficient than the case crossover design. But there are some situations where you may need case crossover design, especially when you don't have certain period of studies that is required for time series, because normally for time series studies, so you need to capture seasonality and long-term trend. So as a result, as you most of you aware that to capture the seasonality, you need at least 3 seasons to understand the pattern. So that's why for time series study, you need 3 years daily data before you plan for a time series analysis. But in case if you don't have, suppose you have a one, in such case, the case crossover design could be best options, because the study design itself tell you, it would be the event would be captured individually. In contrast, the time series analysis is based on aggregated data. It is an ecological study, where case crossover study is more of an individual level. Its individual event would be considered, and that fellows exposure maybe 2 weeks, 3 weeks before. There are mechanisms. Even if we get opportunity future, I can fully dedicate one lecture on case crossover design. And another is the panel study. Normally those are little chronic in nature, so that things that we normally consider as we consider a panel study. For example, suppose you wanted to see whether there is any short-term effect on asthma exacerbations, right? So daily asthma exacerbation is very difficult to collect from any hospital or any clinic. It knows how to manage this. They manage at home. They don't come to the clinic to get immediate guidance from the doctor unless it becomes very worsened. So they know how to manage this. So as a result, you may not get the record. On the other hand, the panel study can help you, where you can actually recruit. You can approach to a asthma clinic and you can recruit, say, 40 participants or 40 individuals or asthmatic people, and you can just follow them for 10-12 times in a year and see whether there is any asthma episodes during that period, and you can effect of air pollution on asthma exacerbation. So it depends on the outcome and the availability of the outcomes. So study design very much would be selected based on that particular aspects. But in this lecture, we mostly focus on time series design. So let me move to time series design. But before that, I'll, the evidence wise and causal inference wise, I would say that panel study would be more stronger one, because it is more individual level study. You have more control on this. As a result, the panel would be, strongest with respect to the causal inference. Intermediate would be the case crossover design, and however time series design will be little weaker because it is an ecological studies, but however it is very, very important study design for intermediate policy, because it is one of the low hanging fruit that can be done very easily without spending much money. So as I mentioned about time series studies, one of the important aspects of the time series study is it captured the entire population as a whole. As a whole. So the external validity is not a problem, because when you are doing a study for, say, Chennai, this study is valid for entire Chennai. However, panel study from somewhere in Ambattur or even in Gindi, it would be valid maybe within Gindi. Then you have to establish the external validity across the city. That problem won't be there in the time series analysis, because it is valid for the entire city population. Here we will consider outcome as either, say, total mortality in a day in Chennai city, or total hospital. You can consider one particular hospital, suppose total hospital admission in Kilpauk Medical College, or Madras Medical College, or Stanley Medical College, those are big medical college. For any, you can target one, or you can target multiple from there, how everyday events. So higher the population, you capture, better the power of the time series. So if you are bigger the geographical region, higher the power of the time series study. So that is what we consider. That's why we consider a city-based analysis in particular time series domain. And then another important factor is here is that you don't need to bother about the confounding, because individual level confounding, because individual level confounding would be average out, because you are taking ecological data, so total all cause mortality, so there's no individual data here. So individual confounding effect would be average out, you don't need to bother. But few things that you need to bother is some factor that actually time variant, and especially some seasonal infections and seasonal epidemic, etc., that you may not have that, but one of the biggest indicator of this is the time. If you can use time as a confounder, as a proxy confounder, it actually serves very nicely. So time can be a proxy confounder for all time varying confounders that impact the entire population. It's not one individual, entire populations. So that's why time is one of the important confounders. Then what are the aspects of the time that we consider? It is nothing but the seasonal pattern of the mortality or morbidity, or temporal trend of mortality, morbidity, how over time the mortality, morbidity is changing in a city, or this how over season, how it follows. Because if there is a seasonal pattern and there is a long-term trend, then those are not due to air pollution effect. So those should be controlled. Unless you control that, you cannot extract the exact acute effect of air pollution. That's why those are the confounding factor, can be easily captured through nonlinear function of time, or any function that can capture the seasonality and time trend, like Fourier transformation, etc. So that we normally do in a parametric time series analysis. But here, most popular technique here, not to do a parametric one, rather look at the semi-parametric technique. that we do. So as I already mentioned that it's 3 to 10 years of time period we consider. Why 10 years? You might say you should not take long time period. That because it should be under 10 years, because population, it's actually outcome is considering daily count of any health outcome. So if the city population increase, so daily count also increase, right? So that's why if you take a wider time period, so the population also will vary. However, there is a mechanism by which you can actually account that population change. But normally, if it is a below 10 years, you don't need to bother about the population change over time, because that change would be very minimal. But longer period, that time you have to account, you can do, but you have to account the population change into this. But however, getting population every year in a city would be very difficult, or every day in a city, every month in a city would be difficult. So that's why we recommend you choose a period that is less than 10 years, such that this population expansion have no impact on this, or have a less impact, less bias the estimates. And exposure is daily air pollution concentration can be considered. And the covariates that we normally consider is one of the important confounder, as I told, time. And this time is a nonlinear confounder. The day of weeks is an indicator. Day of week is Monday. Why day of week? Because the hospital admission or some health events that we consider, that we health count hospital, especially the hospital admission, you can see that weekend is much lesser. Somehow they manage the because they know that they may not get doctors so on weekend, so they can manage and then get admitted in Monday. So that is what often it happens. So that's why day of week is important about the health outcomes. And then the holidays, holidays also, in the same reason, the holidays is also important. This is also an indicator. Seasonality and temperature, seasonality and temporal trend, along with temperature and relative humidity. Temperature and relative humidity are also a nonlinear confounders. Need a special care to adjust them. That I'll come in a minute. Then the statistical methods is a Poisson regression or negative binomial we use for this. And what are the advantages here? It's capture rapid changing exposure and health outcomes, population base, and that's why I told external validity is not a problem, relatively low cost, and can estimate lag structure, delayed effects. But what are the major limitations? The major limitation of this time series study is the ecological fallacy, because an ecological fallacy means, in an ecological level, in an aggregation level, you might see the association, but when you go individual level, you may not see the association, because in population level, when you are collecting these information, some factors are associated to others. And what association that you get in the ecological level, that actually may not be attributed to that particular factor, may be attributed to another factor which is strongly correlated with this factor. So that's why this time series study, the estimate from the time series study, the causal inference we consider as a weak, because the evidence is not so strong. But there is certain reason by which we still consider for intermediate policy change, is because that it's this kind of ecological studies, the exposure misclassification is non-differential type. I don't know whether you people are aware about the exposure misclassification. So exposure misclassifications are two types we consider. One is the non-differential and another is the differential. The non-differential exposure misclassification means it means that the exposure is assessed independent of the outcome. So it doesn't depend on the outcome. So what is the implication of it? The implication could be it actually nullifies the effect. That means it can underestimate the actual effect size. On the other hand, if the misclassification is differential, if misclassification is differential, it is dangerous, because the impact is unpredictable. It can underestimate, it can overestimate. So it is not something like, non-differential where we know it can underestimate, but whatever the association we are seeing, it is true. But differential misclassification cause a huge problem, may cause huge problem. So that's why, the time series study, even though it can underestimate, even though it can be weak evidence of causal association, it's still considered as one of the important, mechanism to for intermediate policy change that has, already, especially, if you look at the 20 years before in Western countries. So this time series study play a very vital role to change the environmental policies, and then that was proven and quantified more accurately by some cohort studies there itself in America and Europe. And another aspect is the nonlinear confounding. So nonlinear confounding, you have to capture the nonlinearity perfectly. So often this nonlinearity confounding, may be unadjusted properly if you are not choosing a proper, pattern or proper function that can capture the, true seasonality and temporal trend of time, as well as temperature and relative humidity. So those are very sensitive to those things that need to take care. And the lag structure, if you look at the lag structure, could be 0 to 7 days, or normally we consider 1 to 3 days lag structure. It could be distributed lag effect, it could be single day lag, it could be distributed lag effect. Distributed lag means it's today's effect, yesterday's effect, day before yesterday's effect, or 3 days before effect, all together, the cumulative effect. So that can be considered, or it could be, the cumulative average effect, or that means the moving average. It could be 2 days moving average, 3 days moving average, etc. And the statistical model, we normally consider a Poisson regression model, and Poisson regression model structure is like this, where, log of expected y is equals to alpha plus regression coefficient in the pollutant plus all confounder. It is time I am showing here, but it should be the f of t is a nonlinear function of time. Normally we consider is either parametric spline or non-parametric spline, and most popularly used spline is the cubic smoothing spline. It could be parametric or non-parametric. The parametric one, you have to estimate the degrees of freedom and you have to specify the degrees of freedom. However, for a non-parametric cubic smoothing, it actually learns from the data itself. So you don't need to bother about the degrees of freedom, but there are pros and cons for both the things. For data-driven problem is, it's very much, if the data has some noise, it can capture higher degrees of freedom. Whereas, you may be aware that in this city, that much degrees of freedom cannot be. It could be some, noise because of some other factors that mortality happened. So that's why you cannot completely rely on the data. On the other hand, for a non-parametric parametric smoothing, you'd have to understand what could be the potential degrees of freedom. So these are the limitations. So this is the model structure. I'll just quickly move how to interpret the data if we get this. So suppose you get the regression coefficient from the Poisson regression model. How do we interpret this Poisson regression model? So now you will get the beta. So beta is, suppose it's very small. The effects, the air pollution effect is very, very small. So 0.0007. So how do we interpret these things? So to interpret these things, what we'll do, we'll convert that into a relative risk. How do you convert the relative risk? You just, as the effect is very small, instead of unit air pollution, you use, most often we use 10 microgram per meter cube increase. So multiply 10 with 0.0007 and then get e to the power of that antilog of that will give you the relative risk. And this relative risk, suppose 1.07. Then how do we interpret? So it interprets that the per 10 microgram increase in PM 2.5 will cause 0.7% increase in daily health outcomes, say daily mortality, daily hospital admission, or daily morbidity, like this. So that's the way we interpret the regression coefficient or the effect size obtained from a Poisson regression model. In this regard, if you have a long-term time series, you can actually consider population as an offset. So if you have the population every year, put the population as an offset. That is an option. So by putting the population as offset, so it will account the population increase in that model, such that you can get a true effect size due to acute air pollution. So one of that important factor is the over dispersion. So over dispersion, those who are aware about Poisson regression or not aware about Poisson regression, is that when you are considering a Poisson regression, the Poisson distribution has one property. That property is the mean and variance are same. But in this kind of data, the mean and variance cannot be same. Variance often is very high. So that's why when you consider, simple Poisson model, so what would happen, false positive rate will increase, you narrow your confidence interval, you might see a significant effect, but it could be a false positive. So it may not, actually it is not significant, but you will see it's a significant. So that's why over dispersion should be taken care. And this over dispersion very popularly, accounted by assuming quasi-Poisson regression model that can be used, and that actually adjusts this excess variability. The other technique could be a negative binomial regression, that also popularly used it before quasi-Poisson regression came. And then another option is that those who are aware about the regression techniques, that in regression we actually model the mean. But if we can model both mean and variance, then this problem won't be there. So mean and variance modeling could be another technique by which you can overcome this. I'm just touching upon the different techniques that you can do it. Please go through the literature and get proper understanding of these techniques. And the major confounder, as I mentioned, seasonality, long-term time trend, that can be accounted by the cubic smoothing spline with suitable degrees of freedom, or penalized cubic smoothing spline by a data-driven options. But you have to check it. That time come in a time, because it's very sensitive. And this is the cubic smoothing spline that we consider, and normally it is 2 to 4 degrees of freedom per year. Suppose you have a 5 years data, your degrees of freedom is 4 years per year, means you would have 20 total degrees of freedom. So how do you understand these degrees of freedom? It is actually, if you do a time series plot of the mortality or morbidity, daily mortality, you can find out the seasonal pattern. From that seasonal pattern, you can understand how many, just simple, how many line can be fitted there. So based on that, you can understand how many split is required. So those split or those knots are actually the degrees of freedom. Through the graphics also, you can get a sense. Otherwise, the goodness of fit technique is there, by which you could be able to understand what should be the appropriate degrees of freedom for this particular analysis. Or penalized cubic smoothing spline will derive the degrees of freedom on its own. So this is all, I explained this, not covering this. I'll cover one more thing that is very, very important. Time is very short, is the lag structure and the multi-pollutant model. The distributed lag structure, because it could be single day, it could be, multiple days, but actual short-term effect could be, multiple days, may not be single day. So how do you capture that? So distributed lag model is one of the popular technique by which you can actually simultaneously estimate the the exposure response with the different lags, and then finally you can combine them and get a cumulative effect of those particular specific, maybe 3 days lag, 4 days lag, 5 days lag. I'll show you one example quickly. So this is the distributed lag model that most often. And then the multi-pollutant approach can be done through a principal component analysis, whether you can, because multi-pollutant problem is the pollutant may be highly correlated. So multi-collinearity is a problem when you are doing a regression. To overcome this problem, I do a principal component analysis and get a score. or you can get a air quality index or air quality health index as your exposure. Bayesian shrinkage methods is there by which you can do. Alternatively, ridge regression is there by you can do, or even most recently, most popular nowadays is to understand the mixture effect on this is the weighted quantile sum regression. So that is these are the technique by which you can actually understand the impact of a mixture or multi-pollutant impact on health. So these are the different R packages that you can use. The MGCB is the most common package that we often use for this. DLNM is the distributed lag package that you can use, and OpenAir is another one that you can explore. And very quickly, maybe just 5 minutes, just the few practical consideration. The degrees of freedom is one of the very important factor. Then compare linear versus non-linear exposure. That means exposure response should be drawn. Then single versus multiple pollutant, lag structure. You look at the autocorrelation also, because it's a time series data. So serial correlation would be there. Whether the temporal, non-linear temporal function is fully captured, that autocorrelation or not. If cannot, then autocorrelation could present in the model, so it might cause the bias. Then goodness of fit through AIC or deviance, and exposure response plot is very important to understand, because we are assuming that the air pollution is linearly associated. That's why we say it's a semi-parametric technique, linearly associated. So whether that association is linear or non-linear, that need to be examined. So this is one of the example I'm giving. The just few years before, we conducted one study. This here we consider the satellite based AOD based Delhi PM 2.5 exposure in Delhi. If you can look at that, here we consider different, exposure metric: 1 day lag, 2 day, 3 day, 4 day, then 2 days cumulative. That means moving average: 2 days, 3 days, 4 days, 5 days, 6 days, 7 days moving average, and then we got this effect. And say for 0.033, that is part 10 microgram per meter cube increase in PM 2.5 cause 0.33% increase in daily all cause mortality. Same like this. And even for the sensitivity analysis, if you look at that, we also look at it is effect modification or sensitivity analysis both together. If you look at here, different season we consider, different gender we consider, different age we consider. Even we disaggregated exposure at district level as well as zip code level, and these are the different effects that you can see. That effect varies across these different choices. And even the degrees of freedom is the right side. If you look at the forest plot, it's showing the effect of choice of different degrees of freedom for time, temperature, and even different lag of temperature. That is showing how sensitive the estimate is with respect to this. This is very important to understand this. And this is the exposure response curve that we drawn here. If you look at that, when 6 days cumulative average is considered, you will get some non-linearity, whereas when single day average exposure was considered, it is just the a linear association. So that need to be confirmed, that there is a sufficient linearity in this. Then only you can understand, or you can actually confirm that this is a true effect size. Similarly, if you look at another study where we considered is the attributed mortality from temperature extreme time series studies in Varanasi, where we wanted to see whether the temperature increase or decrease in summer and winter, what is its impact. So if you look at the forest plot here, you see it is per unit change in temperature in summer, so 5.6% increase in mortality, or per unit decrease in temperature in winter, it is 1.5% increase in mortality. And here we, as temperature was there, we actually did the distributed lag model, and we wanted to see how the cumulative effect of all, up to 7 days lag is this. So now this is the exposure response across different lags. So whatever the curve that you are seeing, what is the impact on same day, first day, second day, last day, yesterday, day before yesterday, third day before, fourth day, fifth day, sixth day, seventh day, on that day effect. and then we combine together, and whatever embedded the effect size is, the odd ratio is 1.039, that is given as the cumulative effect. That means 3.9% increase per unit increase of temperature. So this is the distributed lag model. And quickly another one, if you look at that, this is the differential effect of PM2.5 constitutes on daily all-cause mortality, where multicollinearity was a major problem. And in this particular analysis, we actually implemented Ries regression. So Ries regression is one technique that actually induces small bias and overcome the multicollinearity. And this is what the estimates from that Ries regression technique. And then another one that we actually recently did is develop a framework for city-specific air quality health index, where, as you know, the air quality index is driven from the health response from the Western countries, and it has no link to our Indian health response, and health is not there at all. It's, even if the calculation, when they do these values, health is not a factor there, some factor that multiplier is considered, that is based on some health response from the Western countries. So then we propose that actually we can actually develop a city-specific air quality health index by these time series analysis. So this is one of the work that my PhD student Francio did, and they developed a framework for city-specific air quality health index, where any specific city, you can develop this index through a time series analysis, and that city-specific air quality health index can be translated into the health messaging for that particular city instead of entire country, that one air quality index. So these are the main things, and few if you are interested, you can look at certain literatures for your study for more details about the time series analysis and the short-term air pollution effect. And these are the if in the last book, it's very nice, the Docker is book, it's very nice. You can look at this thing, and the first one is it's a free HI reports you can get, where you will get how actually different methodological things evolve over time, and how this generalized additive model, the same parametric regression, actually settle in this environmental air pollution domain. So these are the some idea about the time series analysis and the short-term air pollution health effect estimation due to air pollutions. But however, I couldn't cover all things. One of the important is, of course, the case crossover design. If I get opportunity in future, can discuss in details about case crossover design, because that is a little complicated, but very important for people who don't have more than 3 years data, can be easily use the case crossover designs. Thank you very much. If you have any questions, please ask.
Yeah, and Dr. Santu, thank you very much. It's a very interesting and highly technical talk, and I hope everybody has enjoyed this. Some questions before we jump onto the questions. I request everybody to start their camera so that we'll have one capture online picture, and then we'll discuss the questions. And if you have any questions, please type on the chat box so that you can also read the question.
What happened? Nobody is switching on the camera.
No, they have. Everybody has switched off. We can see many.
Oh, is then?
Okay. Yeah. So someone can take the picture.
Yes, sir. I've taken the picture.
Thank you very much. So that was a very interesting talk. Actually, I mean, since it is a data-driven model, and most of this, conclusions, whatever we are deriving or summarizing, it's all based on the database. And sometimes the data also varies with the population age, the environmental conditions. So how are we accounting these factors in this kind of models?
No, that, initially I told you, that this, when you are considering ecological study, it is more of a population level. If you feel that age is a factor or sex is a factor, you have to segregate the data with respect to age or sex or any other factor. Maybe, sometimes, you're talking about mortality, maybe institutional mortality, or, you might be interested, maybe, some other epidemic related these things. You need to segregate this data with respect to that particular factor. For example, you might have to get the daily mortality attributed to, say, age above 65, or attributed to gender, or attributed to some other factor, and then you have to separately analyze the data.
Oh, okay. Okay. So, and then the next question is like, you said 3 years data is minimum is required, but, all this, cause effect relationship and the exposure to air pollution, this all requires a long-term cohort studies. So how different if somebody collects only 3 years data and come out with some model, and someone collects more than 10 years data, come out with model. So how are we comparing these models?
So at the beginning of my lecture, I just tried to differentiate the air pollution effect as a acute effect, short-term effect, and long-term effect. That means the short-term response and long-term response. Long-term response is more, permanent damage of the body, and short-term response is just a quick body response through the body immunoresponse that is happens, and because of that whole things happens. That mechanism that I explained, through the inflammatory pathway, lung become vulnerable, get infection. So these are the short-term effect, okay? And these short-term effect only, can be estimated through this time series analysis, not the long-term. The cohort is required for a long-term effect of air pollution. Maybe cancer, maybe coronary artery disease, right? Maybe some neurological disorder. Those are the long-term exposure of air pollution cause this, right? So depression or anxiety is something, could be short-term, but depression could be long-term. So depression also could be short-term, of course, but these are even the many neurological disorder also can be considered as a long-term effect. So for those cohort is required. But here what we need basically, it's not that one person get exposed to air pollution in one day and died. It is not that. It is the people who are susceptible, people who are immunocompromised, people who have, pre-existing illness. When they get exposed to the air pollution, their body responds differently. And it is the impact, or it is the effect of air pollution to those people mainly. So this particular effect we call is an harvesting effect. That means those people who, could have been died, say 2 months after, but due to air pollution exposure died on that day itself. So this is called harvesting effect. So it is just the acute response of the body. What is the impact of, what is the association of air pollution to the acute response? That acute response not necessary to be a long-term damage of the body. Because of multiple acute response, long-term or chronic impact occur because of many short-term, response to air pollutions.
Okay. Okay. Yeah. So there are some couple of questions. They'll put it in the chat box. Are you able to access to the chat?
Chat box. Where is the chat box? I'm not seeing it.
Okay. You just click on that, in the bottom of your computer.
Oh, bottom. Yeah.
So you can see that there is a mute, stop, all those things. Then there is a chart there.
All right. This.
Click on the chart, and then you will see.
Maybe that is chat.
So if you are not able to see, I can read the question for you. So
Yeah, I got it. Sorry, it was minimized that I couldn't see it. Oh, okay. So this is, I'm looking from the top. Arup, How can a time series study capture rapid exposure effects when the recommended study period is 3 to 10 years? If I have 1 year of daily data, can I still use a time series approach? No, Arup, time series, as mentioned, that the time series will be difficult because you need to, very valid point that you have, you need to capture the rapid exposure and the rapid response of the body. So to do this, you have to, remove certain response that occur over time. So that need to be controlled. So unless you control, you cannot actually extract that effect. So that's why minimum 3 years of data is important. If you don't have 3 years of data, that's I mentioned, you can actually plan for a case crossover design. That can be done. That even if I get opportunity later, I can discuss on case crossover design, but that is one design that you can use instead of time series analysis, but it will give you the same effect. So it is the same thing, same short-term impact of air pollution on health. So you can look at the literature, case crossover design related to acute effect of air pollution health. Then Paresh is telling, how can we exactly decide the lag days? Yes, to understand the lag days, you have to consider two things. One is the goodness of fit of the model, see which lags giving a better fit, that could be a stronger lag, and how many such single day lag giving the good fit, right? Then effect size. Now look at the effect size and its precision. So if you see that some lag, suppose you might see that the same day effect, the precision is low, but if you look at the previous day effect, precision is high. And this way, if you go back maybe up to 3-4 days, you might see that the effect size is strong, significant, and precise. So those 0 to 3 days you can consider as the lag effect exists, and those three days can be combined together. Okay, but however, when you look at the distributed lag model, that is the advantage for you. You can see each lag effect up to 7 days, and you can see where it is significant. So in the curve itself, there will be a zero line or line on one. One is the, if it is relative risk, it will be lying on one, this parallel line. If that confidence band touch this line at one at y-axis, then it is not significant. So look at the significant window where you can see a significant effect of air pollution. By this distributed lag model, you would be able to understand which are the lags that are more important for this particular effect size. And what should be the maximum lag? I mentioned that it's maximum 7 you should consider for air pollution. But you should look at 1, 2, 3, 4, 5, 6, where is more dominant. When you get the effect size for each of lag, single lag, then you would be in a position, by the sensitivity analysis, you would be in a position that up to which lag you can actually see the effect of air pollution, acute effect of air pollution. Hope I could answer your question. And then Sanket is asking, which model is more suitable for estimating exposure related health risk across different age groups? For example, IER model or global exposure mortality model. This is different questions. This is not related to this. That are your questions is more of a generic questions, but today we talked about only short-term effect of air pollutions. So the global exposure mortality model, it is actually long-term mortality model. It's not always short-term effect. So there, for burden of disease calculation, etc., we normally fit that and get the exposure response. And exposure response, it is actually considered, it's a different mechanism by which this exposure response is developed. It's a lot of complicated process by which different level of exposure and different health outcomes is considered, and then they are plotted, and then model was developed on that, and that way they get the IER and the integrated exposure response. And that integrated exposure response, it is not acute effect. it could be the regular air pollution impact on health. It is not the short-term response. So this particular lecture is not related to that aspect that you are talking about. Then Dr. S.K. Tyagi asked, very nice presentation, Dr. Ghosh. Do you report accuracy of your prediction and how you take care of uncertainties and report in the outcome of the studies because unaccounted toxic or carcinogenic parameter like pH and VOC, etc. See, here, that is the two different aspects that I am seeing here. One is the exposure misclassification. Yes, that is the problem, that this analysis cannot resolve the exposure misclassification. Exposure misclassification has to be resolved by the exposure scientist. How best you can calculate the exposure or the ambient concentration for any particular pollutant. So you can consider, for example, if you have if you can actually decode the PM 2.5 and get the actual species, you would be able to understand the impact of each of the species as well as joint impact of the mixture. So that problem would be solved. That for that as I mentioned, that the ridge regression and the weighted quantile sum regression is one of the important technique by which you can actually understand this mixture effect. And then other questions that you mentioned about the accuracy of the prediction, it is not prediction at all. Okay, it is an effect estimations. It is not a prediction model. Okay, so prediction is not at all important here. This particular model, time series model, is not predicting the mortality. It is rather estimating the acute effect of mortality that impacted those who are susceptible from all. So that is what it is. It is not, this impact is not all. So if you are predicting the mortality from here, so true mortality cannot be, it is not correct, because this particular association can be attributed to those who have already the pre-existing health condition and their response. But by this mechanism, with even all-cause mortality, you would be able to trace that. But prediction is not attributed to the per day all-cause mortality. Do not use this model for prediction of this. As far as accuracy is concerned, yes, the statistical mechanism is there by which you can understand the goodness of it, and to understand, but most important here, more than the goodness of fit, as prediction is not our major concern, I would suggest you stress on the sensitivity analysis. Look at the factor that can influence the accuracy of this estimate. These factors are the degrees of freedom for the nonlinear confounders. This factor could be seasonality. This factor could be gender. This factor could be age. This factor could be different lag effect, or this factor could be exposure misclassification. So these sensitivity analysis, if you can do and can understand whether how this particular estimate is sensitive to these particular factors that may have potential to make the estimate bias. So if you can prove that your estimate is very less sensitive to these factors, that will prove that your estimate is more robust. Hope I answered the question.
Yeah, Santanu, thank you very much for your talk, and we enjoyed. If on behalf of Air Quality Management lecture series coordination, so we will thank you very much for taking your time and delivering this talk. We see you all in the next upcoming lecture in the month of December. And those who are interested to participate in this lecture series, please type your email IDs or mobile number in the chat box so that we will keep it in our communication network, and we will share the details with you. Again, thank you very much to all for joining this lecture and make this lecture very interesting. Thank you very much. Thank you, Santu. Thank you.